Good afternoon and welcome to this COMPAS webinar on privacy in a pandemic. My name is Eric McGilvray. I'm a professor in the political science department here at Ohio State, and I'm the coordinator of this year's COMPAS series on the COVID-19 pandemic. As many of you know, COMPAS is a program at the Ohio State Center for Ethics and Human Values. COMPAS is an acronym that stands for Conversations on Morality, Politics, and Society. And the mission of the COMPAS program is to promote informed and civil discussion of important and controversial public issues. Obviously, the COVID-19 pandemic is one of the most important and most controversial issues facing our nation and the world today. And today's panel is the second in a series of COMPAS events that explore the ethical and political dimensions of the pandemic and the response to it. We're hosting panels like this one on Zoom every other Friday from 1 o'clock to 2 o'clock p.m. Eastern Time. Our next panel on October 2nd is called Who Gets Sick, Who Gets Care? Inequality in COVID Outcomes. You can view the full schedule and find information about our many distinguished panelists on our website, cehv.osu.edu/compass. It's a great lineup of topics and speakers, and I hope that many of you will be able to join us for those events. Today's panel, Testing, Quarantines, and Contact Tracing, Privacy in a Pandemic, is co-sponsored by the OSU Office of Residence Life and will be moderated by my colleague, Dennis Hirsch. I'll let Dennis introduce our panelists, but first let me very briefly introduce him. Professor Hirsch is Professor of Law and Director of the Program on Data and Governance at Ohio State's Moritz College of Law, and is also Professor of Law at Capital University Law School. He has written extensively about the interaction of governance theory and information privacy law. Dennis, take it away.
Thank you. First of all, let me say what a privilege it is to be a part of one of these CEHV COMPAS events. You guys just unfailingly find really fascinating topics to talk about and bring great speakers, and I've enjoyed the events myself in the past, so I'm very pleased to be a part of this one. As many of you know, contact tracing is an important part of dealing with infectious diseases generally and especially pandemics. And contact tracing historically has been done through trained individuals in, in-person interactions. Given the current pandemic and the increased use of information technology and smartphones and the like in our society, there's obviously the potential for more digital contact tracing. And that has led to a lot of attention to that approach to contact tracing. But of course, when we start talking about digital technologies and the information that is known about us, our location, et cetera, and we talk about collecting and sharing and using that information, that raises important privacy issues. And so we confront potentially a trade-off between, kind of health outcomes and effective contact tracing with digital technologies and privacy. And we need to think very carefully about that whole area. And our panelists today are ideally suited to help us think about that and to bring, I think after hearing them, we will all be better able to bring an understanding to these issues and think about them and discuss them more accurately and more intelligently. So Bill Miller is Senior Associate Dean for Research at the College of Public Health at The Ohio State University. He is an infectious diseases epidemiologist who, in normal times, he says, works in the overlapping fields of sexually transmitted diseases, HIV infection, and opioid use. And he has developed his expertise in contact tracing in that area, leading studies of contact tracing for HIV infection. Currently, he's a member of OSU's COVID-19 Comprehensive Monitoring Team and has consulted with the Ohio Department of Health for COVID-19, as well as quite a number of media appearances to provide accurate information about COVID-19 to the general public. So, Bill, we are just very pleased to have you be a part of this panel. Our second panelist is Woodrow, or Woody Hartzog, and Woody is a professor of law and computer science at Northeastern University School of Law and the Corey College of Computer Scientists. Among his other affiliations, he's a faculty associate at the Berkman Klein Center for Internet and Society at Harvard, a non-resident fellow at the Cordell Institute for Policy in Medicine and Law at Washington University, and an affiliate scholar at the Center for Internet and Society at Stanford Law School. He's the author of Privacy's Blueprint, The Battle to Control the Design of New Technologies, that was published in 2018 by Harvard University Press. I can just say, you know, Woody is a member of the same field as I am, privacy law, and he is among, you know, the most respected and interesting members of our field. So again, you know, it's really a pleasure to have him a part of this panel. So I'll turn now to our panelists and let them present, and then I will ask a few questions, and then we're going to have time for audience questions as well.
Thank you, Dennis. I'm going to go ahead and share my screen here. I have a few slides with my goal really to just introduce the concept of contact tracing, what it is, a little bit of what it isn't, and a little bit about how it's been used for other infections and some of the challenges related to COVID-19. Oops, let's get over here. Now I'll try that. So the first thing I want everyone to think about is to recognize that infectious diseases are different than other aspects of our health. With many infectious diseases, infection is transmitted person to person. And you'll see these dots throughout my talk. Each dot represents a person. The red dots represent someone who's infected. And so because it's transmitted person to person, your chance of infection depends on my chance of infection. And so the little lines there that you see represent the process of an infection, one person infecting another, or in one case over here on the right-hand side, you have one person who's infected 3 other people. And one of the sort of things that I like to remind people is that in this context of COVID, your health is my health and my health is your health. And that interconnectedness is sort of essential to understanding contact tracing and how this whole process works. So to begin, I just want to remind you or have you think about what influences the spread of infectious diseases. So the first one is the infectiousness of the organism. And we know that COVID is very infectious, not the most infectious thing that we deal with. Measles is, as an example, far more infectious than COVID or SARS-CoV-2. The second is the duration of the infection. If an infection lasts a longer time, there's more opportunity for spread to occur. And when you have a treatment sort of works to shorten that duration of infection. And then the last thing, which is really important in the context of COVID, is the contact rate between people. So when on the little figure there to the right, when people interact with one another, there's the potential for transmission. So contact tracing has the potential to affect both the duration of the infection through treatment and the contact rate between people by referring to isolation if someone is infected, referring to quarantine if they're a contact, and using testing to identify additional infections, and then continuing the loop of more contact tracing. So what is contact tracing exactly? Well, it's really the process of identifying someone with an infection, enumerating their contacts, and then informing these contacts that they've been exposed to someone with an infection. In public health circles, we sometimes separate them into 2 processes. Case investigation, which is actually the process of identifying a case and conducting an interview, including identifying who their contacts might be. And then the actual contact tracing piece, which is when you reach out to the contacts that were named by the case. It's important to recognize that it's very much standard practice that the contact tracer does not reveal the case's identity. Obviously, in many circumstances, it's the person who is the contact can figure it out without too much difficulty, but it's not the contact tracer's role to reveal that information. So let's look quickly at how it works. So this is an example. These are the same dots that we had before. So the green people are uninfected people. The red dots that have the little boxes around them are cases. So through our case investigation, we've identified the 4 cases that have already occurred. And the square boxes around them represent putting them in isolation, trying to limit their transmission to the people that they have contact with. The case investigation then leads to the contact tracing element, where the contact tracers will reach out to each of those people that has been in contact with the case. In this case, there's 6 people that the contact tracers are reaching out to for the 4 cases. They would do an interview. They would move these people to quarantine, which is what the circle, the yellow filled circles represent, and try to prevent onward transmission. That's what these dotted lines represent with the bar here. These are infections that have been prevented by the process of tracing, isolation, and quarantine. So when is contact tracing used? Historically, one of the biggest areas is in sexually transmitted infections with syphilis, HIV infection, gonorrhea are probably the biggest 3 in the STI field. Syphilis contact tracing reaches back to the early 1900s, was quite prominent in the 1930s and 40s, and then really honed in many ways in the 1960s. And then when HIV infection emerged in the 1980s, it sort of contact tracing reemerged as a way to try and control it. Just as one example, this is what's called a network diagram. This is linkages between people in a syphilis outbreak in rural North Carolina in 2001. Every single dot on here is connected through other people. This is a very dense network of sexual transmission for syphilis. This actually occurred over a couple of year period, so it's spread out over time. Contact tracing is also used in the context of bloodborne infections. So things like HIV, which can be transmitted when people are injecting drugs, hepatitis C, hepatitis B, and Ebola. The figure on the right here is a contact diagram from Scott County, Indiana, related to a HIV outbreak among people who were injecting drugs. And then finally, it can also be used in respiratory infections. So measles is one example, especially given the relatively few cases that we have in the United States. And tuberculosis is another one where contact tracing plays a major role. And then lastly, we could add SARS-CoV-2 to the respiratory infections that are used, where contact tracing plays a role. Some other names that you'll hear for contact tracing include partner notification and partner services. That specifically refers to the sexually transmitted diseases space. The reason why it's sort of moved to partner services is very often the partners are offered additional care other than just being told that they might be exposed to an infection. We have some real challenges doing contact tracing with SARS-CoV-2, though, including asymptomatic infections. A substantial proportion of people will never develop symptoms, but they may still transmit. We have a period that's very clear of pre-symptomatic transmission, meaning for the 2 to 4 days before symptoms develop, a person may be transmitting to someone else. And then we have a very short timeline. For something like HIV or an STD, if it takes the contact tracer, a week to reach someone, it's really not that big a deal. But in the context of SARS-CoV-2, we really need to act very quickly in order to have contact tracing be effective. So it presents a real challenge to move that quickly. How is it done? Well, historically, it's been done with telephone calls or in-person visits. The people that do contact tracing, you'll hear the term DIS, which stands for Disease Intervention Specialists. They would go in person, knock on a door, explain what was going on, usually after a phone call if possible. Nowadays, sometimes email is used. A lot of times text messages are the first initial contact. Not so much with you have been exposed, but we need you to speak to the health department. Many of the health departments in some areas have adopted video calls like with Skype or Zoom to make it easier, because there's a better interpersonal relationship in that way than just using the phone often. Contact tracing can also do things like use employee rosters and similar information when there seems to be an outbreak going on in a particular setting. So if there was, as an example, if there was an office party and there seems to be a few cases of SARS-CoV-2, the contact tracers may use the employee roster to be able to contact all the people that might have been exposed. And then social media is one that's pretty interesting in the context of sexually transmitted diseases. There's a lot of relationships that are anonymous, except for the handle used on particular websites. And so sometimes the contact tracers use that route to be able to reach people that they would have no other way of reaching. The last one that I'll just add is app-based, and there's essentially two major types of app-based contact tracing. One is GPS, just who has been where, and the other is proximity-based, meaning how close have you been to other people. So GPS-based contact tracing is something like this. This is a Google map with Coons Hall, with a dot at Coons Hall. So the way GPS-based contact tracing would work would be if I had opted into such a service, essentially it would be able to identify anyone else that had opted into that service, use a time frame like 15 minutes in the same general vicinity, and declare us as potential contacts. This has not been widely used yet, but has been considered for COVID in some areas. And then proximity-based contact tracing is intended to be able to reach contacts that you didn't even know you were a contact of in some cases. So this is an example here of a bus where two people are talking on the phone. If they had the appropriate software on their phone, and one of these people became infected in the next, or became aware of an infection in the next couple of days, the phones could have identified that you were near someone with COVID. This last type of contact tracing has been used in a few of East Asian countries, Singapore being one of the examples, where they have both an app on a phone and a little device that you can carry around. Their system is called Trace Together. Basically, if you're within a close enough space where Bluetooth can recognize that another phone is also sending out the appropriate Bluetooth signal, then there's a linkage, and essentially then a flag can come up if one of those people becomes infected. As of July 2020 in Singapore, 2.1 million people had opted into this device, which is 35% of the population. And one of the things to recognize is that this type of contact tracing really needs a pretty high opt-in rate to be effective. China used a similar kind of thing where it was, let's just say, not really opt-in, but everyone was more or less mandated to do it with some potential benefit. I will add that there have been no trials of any kind of app-based contact tracing. So how effective they are is completely an open question. So I'm going to finish with just two things. The challenges with SARS-CoV contact tracing include trust and privacy. I expect Woody will talk a lot more about privacy than I have. I'm just going to raise the question of trust, though, also. Even without any apps, without any technology, contact tracing only works when society trusts in the process. And we are in a place where we have not nearly the trust that we need to have for contact tracing to be effective. And an example of that is we helped the Ohio Department of Health with a serology study, a study of SARS-CoV-2 prevalence, and there was just much less engagement in the study than you would like, in part because there was very little trust in the community of what was going to be done with that study. And that wasn't contact tracing, but the same principles have been seen when you do interviews with people that have been doing contact tracing in the community. So in conclusion, contact tracing is an essential tool for mitigating infectious diseases. COVID-19 presents special challenges, but without trust, contact tracing really isn't able to do the job that it needs to do. So let me stop sharing my screen and see if I can get out of here. Oops, there, that's what I need to do. There we go.
Excellent. Yeah. Thank you, Bill. That was really great and helpful. Thank you very much for that very clear explanation of what contact tracing was. And thank you to the Center for Ethics and Human Values for having me today. And thanks to Dennis. I want to say that I think that I will talk about privacy. My research area is in privacy, and I've been trying to follow this debate around disease surveillance generally in privacy closely since we've gotten to the beginning. And Bill, I thought it was interesting that you said we need trust and privacy. And I completely agree with you about the trust point. And I think that actually trust and privacy are closer related than many might think. In fact, those are two very closely linked aspects of this. And I'm a little, I have to say, I had heard sort of, it's interesting to hear you say that the efficacy of these proximity notification apps is still an open question. I had wondered about that, but to hear you actually say it actually confirmed a lot of what I was going to say in my talk. So it's very helpful to hear you say that. So there are a number of concerns, and I want to sort of talk about the big picture rather than focusing on some of the minutia privacy specific questions we have, which we could get to maybe in Q&A or something. But the very first question that I have about all of this, and that a lot of people who are looking into the privacy implications of proximity notification have, are questions around efficacy. Because one of the things that I'll get to in a second is that when we adopt these proximity notification systems, not just the apps, but the whole surveillance systems, and we adjust our norms to them, we're entrenching a series of practices that inevitably have some strong trade-offs with respect to privacy. And if the efficacy is not there, then it represents a massive opportunity cost where we're diverting time and resources and money and energy away from things that I'm getting Bill, can you hear me okay? I'm getting an error. Oh, you can? Okay. Time and energy and resources away from things that are really important. So one of the things that I wanted to throw out there is if we're not getting enough uptake or participation, then it's possible that there's not enough efficacy there to justify this. If these things are generating not enough notifications or too many notifications, then it's possible that the efficacy is not there to take this on. If the privacy trade-offs end up being too high in the long term, which is very difficult to tell, then it's possible that the uptake is simply not worth it. I'm getting some messages that my sound is a little bad. I apologize about the connection. I'll try to adjust my settings a little bit. Is this any better? Can anyone hear me any better now? I can only see Dennis and Bill, so give me a thumbs up if my sound is coming through any cleaner now.
It's about the same. It's
about the same.
You can hear it, but it's a little garbled, but you can still understand it.
We can understand you though, Woody.
Okay. So putting the big questions of efficacy aside, I think that with respect to privacy, we have a lot of really bad options. And I've been explaining this to my kids who are going remotely to school, that it's all bad options, right? This is like the movie Argo, where they say, that's a terrible option. Is this the best option you have? And you just have to choose the best bad option. And a lot of the specific fault lines we've been talking about in the privacy community are these big questions around things like whether the app will be decentralized, whether the proximity notification will be decentralized, meaning a lot of the data that's being collected will be stored locally on your phone rather than in a central repository. And there are some major privacy advantages to that, but of course it also means that less information is getting to public health authorities for meaningful disease surveillance. So that cuts down on the efficacy. There are questions. Bill did a great job thinking about, do we want location? Do we want Bluetooth, proximity notification? Do we want both of those things? Because that's the best. Because more information is ostensibly better, but there are also privacy trade-offs there. Do we want to make it mandatory so that trust isn't a question? We just force people to use it. But even then, that creates some that potentially creates some weird incentives for people to try to thwart this system when they're being coerced into it. We see a lot of people create workarounds. People start leaving phones at home. And so it's unclear that even mandatory will get us to where we need, but the opt-in does require trust that I agree with Bill is simply not there yet, at least my general sense of it. So, and so I want to zoom back then from the sort of specific questions and get to the more general questions about privacy and disease surveillance generally, particularly with the use of technology. And my big point that I want to make is I want to caution strongly against an over-reliance on technological solutions that are unproven in this context at the expense of solutions that the public health community has said are proven and effective, things like testing, masks, human contact tracing, to the extent that we can do that. And the reason why is because there are all of these dangers that give me caution before I embrace widely a sense of proximity notification. One of them is that a lot of the advocates of the proximity notification apps have pointed to the fact that companies have done a good job of privacy engineering, and in many ways they have. It's quite impressive the way in which they were able to very quickly create a lot of these APIs. For example, Google and Apple coming together and creating this proximity notification system. But there are only so many things that companies can control. So even the best intentions of private technology companies to protect privacy are dependent upon a larger regulatory ecosystem that is going to help support them. And I don't know if we're there yet. The second thing that I worry about by embracing a technological infrastructure that will allow for greater surveillance is that mission creep with respect to these apps seems almost inevitable. Governments have a long track record of seeing surveillance infrastructures that were created for one purpose and saying, you know what, that would be a really great thing to use for a different purpose. In the same way that we are now talking about leveraging existing surveillance infrastructures that were not built for disease surveillance and leveraging them for that purpose, right? And sometimes those purposes we might say are worthwhile or benevolent or good, and other times we would consider them abuses of power. The third thing I really worry about is that there's a narrative that's been floating within the regulatory community about, well, we can just roll this back, right, as a privacy. Like if there are any major privacy concerns, we will have massive surveillance now, and then when this pandemic is over, we'll just wrap it up, right, and we'll pull it on back. And that's a fantasy. A long history of proposed temporary surveillance provisions have shown that we will still continue. We had temporary authorization of mass surveillance in the wake of September the 11th. The USA Patriot Act had sunset provisions, and we're still reauthorizing them every single time they come up for reauthorization. We've been fighting the war on drugs for how many years? And so we don't know exactly when we would, there's no clear line when we would say, you know what, we have beaten COVID, wrap up the surveillance. Particularly because it becomes politically difficult to argue that we should have less disease surveillance that could, in fact, worsen our public health outcomes. Another reason why I have some worry about privacy in these COVID apps is we haven't done nearly enough pushing at the boundaries of what regulatory frameworks might be deployed to actually make meaningful and sustainable disease surveillance possible. We keep using the same regulatory solutions to try to solve this problem. One example is the temporary legislation that was introduced with, to enable more sufficient disease surveillance was heavily relying upon the notion of consent, right? That don't worry, we will not use particular kinds of information without asking you first. But consent is a broken regulatory mechanism for privacy. We have experienced a number of different failures at the regulatory level. Anyone that's clicked on an I agree button and hasn't read a single thing that's in it will know that consent doesn't really actually protect the privacy in the way that we would want. As part of an experiment, I downloaded one of the proximity notification apps and read their terms of use, and it was something like 14 pages of legalese. And so consent is not meaningful, yet we keep on trotting it out as though it's the solution. And this is actually an opportunity, I think, to use the impetus for a need to create a different framework that allows us to both protect privacy and garner the trust that Bill identified as so important for meaningful contact tracing in a way that can change privacy for even non-disease surveillance regulatory frameworks. So thinking about having maybe duties of care and loyalty placed upon everyone who collects that data, relational rules. This is an opportunity for the United States to rethink its approach to data privacy and we are blowing it. We simply aren't exercising as much regulatory imagination as we could. And then on top of that, none of this will matter if we don't fix the informational environment within which all of us operate. Social media is continuing to amplify misinformation and disinformation that is actually undermining our best public health efforts. And so the trust that was so critical is being eroded outside of what's happening with the contact tracing apps, because we have, as is not surprising to anyone, a massive disinformation problem in our information ecosystem. So even if we solve the close privacy problems with proximity notification, we're still going to be dealing with this larger problem that may blunt the efficacy of these initiatives overall and make them not worth it in the first place. And we will have laid an infrastructure of surveillance for almost no gain. And so to summarize, I think we should consider moving away from a lot of what I think I see as magical thinking and maybe over-enthusiasm for predominantly tech-driven solutions to respond to COVID-19, particularly if it comes at the cost of opportunity cost of lots of other initiatives that we have a much greater confidence will work, like initiatives around wearing masks, initiatives around human-based contact tracing, and different kinds of focuses that I think would have better public health outcomes overall and not jeopardize our privacy. When we over-rely upon technological solutions, we defer too much to technology companies that in a way that will make data leakage and mission creep almost inevitable, both for government and for the tech companies. We defer to private sector solutions that let tech firms identify the values that are at stake and design tools to serve those values in a way that's not necessarily informed by public input, through our public institutions in ways that we think represent all of public, and in ways that ignore or exacerbate pre-existing patterns of inequity that are built into a lot of these technological tools, not only because many of these tools that deploy artificial intelligence and surveillance tools are biased against people of color demonstrably, but also marginalized communities, specifically people of color, bear the brunt of surveillance first and hardest. And if we defer too much to technological solutions, I worry that we miss out on a more effective solution without sacrificing a lot of other values like privacy and continuing to erode the trust, the important trust that people need between in public institutions in order to make meaningful disease surveillance work. Thank you very much. And I apologize for any sound quality issues.
Thank you, Woody, for that quite provocative presentation, and Bill, for your kind of really excellent introduction to kind of how all of this works and what the options are and what the context and the history is. Woody, you said something to my ears kind of provocative at the end there, which is we should not rely as heavily, we should not look to technology necessarily for the solution here in terms of contact tracing, because of the potential for mission creep and possible downsides on the privacy front. So let me ask you, Bill, what do you see as the potential for digital contact tracing? Can we in fact do without it? How important is it? In order to evaluate kind of Woody's comment that maybe we shouldn't rely so heavily on that. Can we do other types of contact tracing here? And I'm speaking specifically about the COVID pandemic that we're in right now.
Yeah, sure. So it's most states, across the United States, across much of Europe, people are doing contact tracing in the old-fashioned way without any true app support. And in many places, it works really well. In New York State, it's worked quite well, as an example. It depends a lot on the context and how it's done and the resources available. So to do it really well, you need a lot of people. And that's probably the biggest thing. So many places are understaffed. So with that information, though, you can do it very well. And a big part of it is testing also. Like contact tracing, even with COVID, is most effective if you can test the contacts quickly so that you can keep the chain going if they're positive. In other words, when you find a contact, you test them right away. If they're positive, then you start the chain again. Our testing limitations, especially when people try to limit testing on asymptomatic people, that affects our contact tracing effectiveness. As I said earlier, the app-based contact tracing area is, I think there's probably a gazillion companies that are trying to develop an app to do it effectively. But as I said, not a one has actually done a field trial of does it make a difference. And it's really easy to come up with these things that we think are good ideas, but you have to show that they actually help. And we haven't done that hard work yet, in my opinion.
Interesting. And so Woody, how much would you recommend moving away from digital contact tracing due to the privacy concerns that you raised? Do you think we can do this another way through traditional contact tracing, or do you think we're going to need digital contact tracing, whether it is, the GPS approach or the proximity-based approach that Bill was outlining before?
Yeah, I think that I'm increasingly convinced that we should move away from it until there's some proof, because once we lay the groundwork, surveillance inertia is going to carry this thing for a long way. And even on top of that, I worry that it's going to take away attention from testing, which I think most of and I hope Bill would agree with me, testing is the really key component of this. And so until we have a better framework, I don't know if we can meaningfully implement proximity notification at all in a way that's going to either be effective or protect our privacy.
I heard you raising these questions of mission creep as something that's of central concern to you. We start to collect and share this information for one purpose, and then which serves an important public health purpose, but then it creeps over into something else. What are the other uses of this information that you're worried about? And are there legal protections, against mission creep? Can you build in sunset provisions to law? What's the role of the Fourth Amendment here when we talk about law enforcement, for example, using this information, or ICE using this information in the immigration context? What are your concerns, and what's the possibilities for the law to limit things and allay those concerns?
Right. So this is a really great question. And I think of mission creep on two planes. One of the planes is mission creep that can occur at industry level, right? So if the app is collecting personal information, then how long is it stored and what else are they using it for? And we may have some relatively good data protection based rules. Data protection is sort of built around the idea, at least the GDPR is built around the idea that if you collect information for one purpose, you shouldn't be using it for a different purpose. We have potential data minimization requirements that say when you're done with it, delete it. So it's not as though there's nothing in the world that prohibits us. But in the United States, of course, we don't have the GDPR, and it's not nearly effective. And the Schrems II decision, for those that aren't familiar, the framework that allowed the United States, companies within the United States to collect data on people in Europe was invalidated because the European Court of Justice looked at the rules, the privacy framework we have in the United States, and said, this is about as effective as a wet napkin. That's paraphrasing. That's not the actual language that they used, but we don't have a strong set of safeguards that protects people from mission creep, not only within industry, but even I think of much more concern to specific groups of people is mission creep at the government level. So even if people do collect, do have a growing sense of trust or enough trust to trust public health authorities, to the extent that there's a porous boundary between public health authorities and law enforcement authorities, then that's going to corrode that trust even more, right? So people will say, are you going to give this information to ICE, for example, or are you going to give this information on people's location to local police departments? And so some of the most important privacy frameworks that we have give public health authorities, like many other health professionals, robust obligations of confidentiality, of care, to take care of particular kinds of data. But the government, to the extent that they try to undermine that for mission creep, is going to collapse I think the whole system in an attempt to leverage data that was collected for public health for things like immigration enforcement or law enforcement or things along those lines.
I'm going to move to some of the questions from the audience, and let me encourage the members of our audience to, submit your questions. We have a bit of time for our panelists to address them. Trying to kind of group the questions. The first group of questions really concerns contact tracing with respect especially to marginalized communities. One that was mentioned was the undocumented community, for example. And I think that raises two issues. On the one hand, if marginalized communities have fewer resources to participate in contact tracing, smartphones and the apps that go along with it, for example, can they be included? How do we include enough people to make, if we do go the route of digital contact tracing, how do we include enough people to make this effective? Should we be giving out free cell phones and data plans to people? On the other hand, if information is collected from these communities, and here the questioner was specifically concerned about the undocumented community, what can be done to ensure confidentiality?
I mean, I'm happy to at least address some of this. One of the reasons that the efficacy question has to be answered first is precisely, I think, because of the risk that we're seeing that will be borne by many. And some people have proposed sort of giving out phones to everyone, but that's basically creating a massive surveillance infrastructure that is going to be irresistible for others. And I don't know if there's any guarantees that we can give, given what we've seen about the long history of wanting to co-opt information collection systems for other purposes, particularly given the state of play that we're dealing with respect to undocumented people. I think that given the mistrust that Bill said is absolutely critical to make this work, I don't even know if giving out the phones would get us there in the first place. Because you then would have to convince people to adopt them and to use them. And I don't know what sorts of safeguards we could build in, because even design, even if you build something so as to not collect certain kinds of personal information, even that is not sacrosanct. We've already seen governments requesting Apple and Google to modify their API so that it would allow for the collection of more information. Like that, we see governments trying to influence the design of information technologies all the time. So, so I come from a great degree of reluctance around that. But I'll let Bill speak to the efficacy question more.
Well, I would simply add that with marginalized communities, undocumented, homeless, first of all, it's often a challenge to do traditional contact tracing just because of lack of access, lack of trust, not having a phone. I mean, you need a phone for regular contact tracing too. It's just used in the old-fashioned way. So many of the best health departments spend a lot of time building trust in those communities to be able to engage them effectively. And I would just add that there's another strategy that's related to contact tracing is what's called case finding, which is if you see a cluster of cases in a community, you may do targeted testing among that community to try and identify cases, even if they haven't been explicitly identified as a contact. And that can be quite an effective mitigation strategy. But again, even that requires trust. People are quite suspicious when you just show up wanting to do tests on people.
Just a quick follow-up, Bill. And I know, I've been hearing about digital contact tracing and, some of the privacy issues and other questions around it, potentially its effectiveness, since we first became aware of the potential for a pandemic. Why is it that we don't have data yet on the effectiveness of using technologies in this way? It's, 6, 7, 8 months later now.
Yeah, a couple of reasons. One, first of all, the Google, Apple promised device, not device, but update of their operating systems, which would share information. It didn't get a broad uptake. Only a couple of health departments that I'm aware of chose to opt in with it, North or South Dakota being one of those. And then I don't think that they had very many people opting in once that software became available. And really for these to be effective, you need, probably 70–80% of the population to be buying into the idea in order for it to work effectively. But that's actually a research question, right? Like, how many people do we need to actually have a device like that? Even in Singapore, which is a highly technical savvy society, the data is 35% opted in. That's not very high. In Korea, it was a little higher, where they had a similar kind of app. But the reason why we don't have the data is because everyone in this whole pandemic, everything is moving at such a pace that we're not doing the studies to actually collect the data. We end up with lots of observational data that's sort of half-baked. But this is the kind of study where you could do, if you really wanted to, you could do a really nice, what would be called a cluster randomized trial and assess like what kind of a difference it actually makes in a community. But there haven't been any proposals that I've seen for that. Each
of you have talked about trust and the importance of trust here for this type of approach to work. And a couple of our questions talk about trust. One asks whether contact tracing was better accepted in the syphilis and gonorrhea context than for HIV. And then comparatively, for HIV, perhaps better than for COVID. What is driving the mistrust? Is social media part of this? And I think, along with that, how do you build trust for this type of thing?
Yeah. So for the first part of that question, I think in the 60s and 70s with gonorrhea and syphilis. Those are not really high incidence nor high attention kind of infections, generally speaking. And it was done in a personal way. Almost in those days, it was in person, which actually makes it a little bit easier to build trust than if you're remote. HIV did have major issues with contact tracing in terms of trust, but that was because HIV was really politicized right from the start, at least in part, and people did a really poor job of messaging the dependency in the way that we need to think about contact tracing. And I think, honestly, in this era with COVID, that's a big part of it. Our country as a whole is a very individualistic one. We're very used to thinking that I take care of my own business and what I do is my own business. And we aren't used to thinking about that my business may actually affect your business. And that's what contact tracing is all about, right? Like, you might not have even talked to me, but you were standing in my space or sitting on the bus next to me. And if I was infected, I've exposed you, I've put you at risk. And we have to have a little bit of open-mindedness in that space in order to have a reasonable public health response.
We've only got a couple of minutes left. Woody, did you have a thought you'd like to share?
Sure. Well, just to answer that, I think you nailed it, Dennis, when you talked about sort of social media as playing and I'll say internet platforms generally playing a key role in a lot of this. One, because they have played a key role in poisoning the public trust generally by amplifying misinformation and disinformation in a way that it runs contrary to our public health goals. But the other reason is generally the pandemic has hit us at a time where the public has started to realize that tech companies generally have abused the public trust. In other words, there were lots of promises made earlier about things that tech companies could do, and now we're sort of turning sour on that in the wake of Cambridge Analytica and a lot of the Snowden disclosures with respect to government. So the way we get it back, I think, I would agree with Bill, is it has to start with us, and it has to start on almost a person-to-person basis, it feels like. Trust is hard to gain and easy to lose. And so it's going to be a long slog back.
Well, let's hope that we're all up for that long slog and doing our part in it. And I think having accurate information about these issues is a place to begin. And each of you has provided really accurate and useful information and perspective. We're out of time for our webinar. Audience, I know you're out there in virtual land. I hope you join me in thanking our speakers for a really interesting and enlightening discussion. Thank you very much.
Thank you, Dennis. Thank you, everyone.
Thank
you,
you,
Bill.
Thank you, Woody.